And good morning, everyone. So it's a pleasure to have Dr. Torbenson with us this morning. Dr. Torbenson was a graduate of the University of Minnesota, the Duluth campus, where he was as an undergraduate between 1987 and 1991. And then he went to the University of Chicago for his medical school education. This he followed with the residency program at the UPMC and also a liver transplant fellowship at the UPMC between 1995 and 2000. He completed a second fellowship in GI pathology at Johns Hopkins University in 2001, after which he stayed on as a faculty between 2001 and 2013, rising to the rank of a full professor at Johns Hopkins University. Early in his career at JHU, he won the Young Investigator Award in the Department of Pathology. He also won the Johns Hopkins Clinician Scientist Award and the Faculty Teaching Award, among other things. Since 2013, Dr. Torbenson has been a professor of pathology at the Mayo Clinic in Rochester. He's quite a very versatile researcher, and he has published more than 280 manuscripts, most of which are original research, but it's also published about 19 review articles and 5 book chapters. He has published 5 textbooks in liver pathology, including the most recent one, which is gaining a lot of popularity already, the Atlas of Liver Pathology, a pattern-based approach, which I think was released about 2 or 3 years ago. I didn't know this, but I just realized that Dr. Torbenson has other interest in archaeology and history of medicine, and has actually published about 9 articles and chapters on this topic. Mike is really well known for a lot of things, but probably most well known for his mentorship. Many of his trainees are quite successful and leading pathologists in liver and GI today. He has also been a leader in our understanding of hepatocellular neoplasms, and one of his major achievement was in reporting what we now know as a very specific translocation in fibrolamellar carcinoma. So I'm sure we are going to hear more about that this morning. He is a former president of both the Hans Popper Hepatopathology Society between 2016 and 2018, and also the Roger Haggett GI Pathology Society between 2019 and 2020. He has lectured extensively nationally and internationally, and has been a director of very successful liver pathology short courses at the USCAP, among other courses that he has presented nationally and internationally. So Mike's CV is many pages long, and I'm not sure I can do justice to it, but it's with great pleasure and honor this morning that to welcome him, Mike Torbenson, and a very good friend, to deliver our department's grand round this morning. So the title of his presentation is Fibrolamellar Carcinoma, Morphological and Molecular Findings. Mike, over to you.
Thank you very much. Let me just get the shared screen up. Can everybody see my screen okay?
Yes.
All right, well, thank you. Thank you for the invitation, Deli, and thank you for being such a great colleague and friend and neighbor. We're also happy when Deli came not that many years ago from Canada to the University of Minnesota. So it's great to have you so close by. So yeah, the talk today will be on fibrolamellar carcinoma, and I'll be talking about some of the unique clinical, pathological, and molecular findings. No conflicts of interest. And we'll go through it in a fairly systematic fashion. We'll start off talking about the history of fibrolamellar carcinoma. We'll talk about some of the clinical findings, the histological findings. We'll talk about how the diagnostic methods have evolved over time. So how we diagnose fibrolamellar carcinoma is different now than it was 10 years ago. We'll talk about the molecular findings, and then we'll spend just a slide or two on future directions. So just a few words on the history of fibrolamellar carcinoma. It was first illustrated in the first AFIP liver tumor fascicle by Edmondson, where he described it as an example of a low-grade hepatocellular carcinoma. But for the next 20 years, from 1956 to 1976, it is still lumped in with the entity of serous hepatocellular carcinoma. It wasn't until 1976 that another really famous liver pathologist named Peters clearly distinguished fibrolamellar carcinoma from serous hepatocellular carcinoma. He did that in a book chapter, and he did that, he distinguished the two based on the younger age for fibrolamellar carcinoma and their apparent better prognosis. But it wasn't until 4 years later that Peters, along with other colleagues, wrote the classic paper. So this paper came in 1980 that described fibrolamellar carcinoma in a detailed fashion and gave it its current name, fibrolamellar carcinoma. And so that is the current name, fibrolamellar carcinoma. It certainly has had other names over time. It was first described by Peters again as eosinophilic hepatocellular carcinoma with lamellar fibrosis. And there's nothing wrong with that name, but it certainly is a mouthful. So you can see why perhaps there are better candidates, such as fibrolamellar carcinoma. It was also called polygonal cell hepatocellular carcinoma with fibrostroma. Both these really emphasize that the tumor cells are big, that they're pink, and that they're associated with this distinctive fibrosis. Fibrolamellar hepatocellular carcinoma was used in the 2001 AFIP fascicle and is still often used today. But the current WHO uses fibrolamellar carcinoma, and that is the original name that was given to it in that 1980 paper. Well, let's review some of the important clinical findings. In terms of the epidemiology, it makes up 1% of all hepatocellular carcinomas. Now, it is clearly enriched in teenagers and young adults. So 30% of all hepatocellular carcinomas in this age group are fibrolamellar carcinomas. And, depending on the study, that can be as high as 50%. But I also want to emphasize that in this age group of teenagers and young adults, conventional hepatocellular carcinomas are also common, and in some studies are predominant. And so just because a patient is young and just because a patient doesn't have underlying liver disease does not automatically make it a fibrolamellar carcinoma. Now, in contrast to conventional hepatocellular carcinoma, fibrolamellar carcinoma does not have a strong gender predilection. In some of the bigger studies, there might be a very slight predilection for female gender, but nothing distinctive as you would see in conventional HCC. Again, in contrast to conventional HCC, where we know many of the risk factors, such as chronic viral hepatitis, alcohol use, fatty liver disease from the metabolic syndrome, et cetera, currently the risk factors for fibrolamellar carcinoma are unknown. That's not for lack of trying, but to date, we have not been able to identify etiological agents. I've talked about the young age, and just to reinforce that point, the mean age is 26 years, and 80% of all fibrolamellar carcinomas occur between the ages of 10 and 35 years, so a very strong cluster in this age group. But there are age extremes. I've certainly seen cases that are bona fide fibrolamellar carcinomas as early as 4 years, and the oldest I've seen was in the early 60s. And so they certainly can occur at the extremes. Just remember that the vast majority cluster in this younger age group. They have no underlying liver disease, and that's 99% of the case. Given a long enough timeline, I'm certain there will be occasional cases that do occur in a background of liver with some fibrosis or other underlying disease, but those underlying diseases would be unrelated to fibrolamellar carcinoma, and those co-occurrence would just be by chance. Serum AFP in fibrolamellar carcinoma is negative or shows some mild nonspecific elevations due to mass effect. If the serum AFP is truly positive, like let's say it's over 200 nanograms per milliliter, then it's really very unlikely to be a fibrolamellar carcinoma. And that can be an important clue if you're struggling with the case. Now, several registry-based studies have suggested there might be a second peak of fibrolamellar carcinoma in the 70s. Now, I think that's certainly possible. The data there hasn't been confirmed by looking at the cases histologically. And certainly some of these cases are probably misdiagnosed, but it remains a distinctive possibility that there might be a second peak in an older age group. Now, in terms of the prognosis, for many years, it was thought to be better. And that is true if you compare it straight up with conventional hepatocellular carcinomas. But if you compare fibrolamellar carcinoma to conventional hepatocellular carcinomas that occur in patients with no underlying liver disease, then the prognosis is quite similar. So again, this is an important paper that came out in 2005 written by the San Francisco group, plus some of your colleagues over at Adeyi with Larry Burgart and Ken Batts. In terms of the histology, this is again the seminal paper written in 1980 by Peters, and the first author is John Craig. John Craig is pictured here. He's a wonderful guy, very funny, very interesting to talk to. And they describe the cytology, the histology of fibrolamellar carcinoma. And they emphasize the big polygonal cells that have abundant eosinophilic cytoplasm. The nuclei have vesiculated chromatin, the nucleoli are prominent, and the tumor cells often have pale bodies that you can see over here. Now, they often have little round dots of bile that you can see here, and these are thought to be malformed bile canaliculi. And so they often have some cholestasis in the tumor cytoplasm, but it's generally not the diffuse tumor cholestasis that you might see in a benign liver. I mentioned the pale bodies, and here again, you can see some nice examples. Now, these are not specific. You can certainly see these in conventional hepatocellular carcinomas. So again, enriched in fibrolamellar carcinoma, but you don't want to hang your hat in terms of making a diagnosis solely on the finding of a pale body. When people do EM on these, they found, or they believed, that these start off as bile canaliculi that are mislocated into the cytoplasm of the tumor cells, and that they become filled with different secretions. Those secretions become very concentrated, inspissated, leading eventually to pale bodies. Fibrolamellar carcinomas can also have these very eosinophilic hyaline bodies that you can see nicely shown here. Now, these hyaline bodies for a long time were thought to be the end stage of pale bodies, but if you look carefully, they don't co-localize. In other words, you don't see hyaline bodies in the same area of the tumor that have the pale bodies. So it's not completely clear to me, at least, whether these hyaline bodies are the end stage of the pale bodies. In any case, you can certainly see them, and just remember that they, again, are not specific for fibrolamellar carcinoma. You can also have pseudogland formation, and this can be a real diagnostic pitfall, and I've seen some consult cases with that. These tumors were misclassified as cholangiocarcinomas, and you're not going to be surprised. Why, right? You can see these distinctive pseudoglands. Occasionally, you might have some glands that form some mucin. The mucin that can be weakly mucichromine positive, but certainly can be highlighted by LCM blue. And this, again, can be an important diagnostic pitfall. Other areas can have myxoid change. And so here you can see the fibrolamellar carcinoma with some myxoid stroma. And sometimes when they metastasize, the myxoid stroma can be very striking. Here you can see an example of a lung metastasis with abundant myxoid stroma and just a few scattered tumor cells within that myxoid material. Fibrolamellar carcinomas can also have fatty change. And so this is not surprising. Again, if the patient has the metabolic syndrome and has some fat in the background liver, you might find some fat within the tumor itself. Occasionally, they can have microcalcifications. If you look for them carefully, you actually see them a lot more often than you would expect. And the radiologists see them even more often than we do. But if you see a microcalcification, certainly consistent with fibrolamellar carcinoma. But again, not going to be diagnostic. Now, as part of the name fibrolamellar carcinoma, you have this distinctive fibrosis, and here you can see it shown very nicely, these lamellar bands of fibrosis, so fibrolamellar carcinoma. Now, the fibrosis is not always this well organized. In fact, in most cases, it's not, but this is a nice picture to illustrate the lamellar characteristics that are present in at least some parts of most tumors. But in other areas, the fibrosis may be much more haphazard. In fact, the center of the tumors can be almost acellular and just, dense, heavy fibrosis. And in some areas, you might have a tumor growth that's relatively solid with almost no intervening fibrotic stroma. So that just gives you a sense of the variation, the heterogeneity that you can see in the fibrotic component of fibrolamellar carcinoma. Now, at the periphery of fibrolamellar carcinomas, in some cases, you can have a FNH-like response. This is not truly a focal nodular hyperplasia, but you can see some of the features that might lead to that consideration. You have these nodules of hepatocytes, these bands of fibrosis. The background liver is non-cirrhotic, non-fibrotic, and so It looks like a fibrolamellar carcinoma. And if you do a it looks like a focal nodular hyperplasia. And if you do a glutamine synthetase, it will show a patchy staining pattern that you associate with focal nodular hyperplasias. And so this led to some thought, probably about 20 years ago, there was a flurry of papers raising the possibility that FNHs, focal nodular hyperplasias, may be a precursor to fibrolamellar carcinoma. But we now understand that that's not the case. But instead, sometimes fibrolamellar carcinoma can lead to vascular shunting, and that shunting then in turn leads to an FNH-like response at the edge of the tumor. So let's talk about how we make a diagnosis of fibrolamellar carcinoma. So let's say you're looking at a tumor, and, it looks like it's okay for fibrolamellar carcinoma, and it's the right age, young person, and you look at the history as best you can, and there's no known underlying liver disease, and you think, well, okay, it's probably fibrolamellar carcinoma, but the question remains, how do you know for sure that that's the correct diagnosis? Establishing a correct diagnosis is important for patient care. The conventional treatment that we give for patients with hepatocellular carcinoma is ineffective in fibrolamellar carcinoma. Most patients with fibrolamellar carcinoma are now enrolled in distinct special clinical trials whenever possible. And so it's certainly an important aspect of patient care. Of course, it's critical if we're ever going to make progress in understanding the biology and treatment of fibrolamellar carcinoma. We have to have a peer group of tumors that we can study. And so it's important for a variety of reasons. So making a diagnosis of fibrolamellar carcinoma for a long time was a single step. And that was this: the tumor should look like fibrolamellar carcinoma on the H&E. It should have big pink tumor cells, prominent nucleoli, should have pale bodies maybe, should have hyaline bodies maybe, and most of them should have intratumoral fibrosis, and the background liver should be non-cirrhotic, and that's how we made the diagnosis. And that again was the H&E era of diagnosis, and that lasted for several decades, from its first description or first major description in 1980 for many years. Well, in 2005, I was a young faculty at Johns Hopkins, and I wanted to study some of the molecular biology of fibrolamellar carcinoma. So I pulled the cases from our pathology and consult archives, and I got them all together. I looked at them. And as I looked at them, I realized that about 20% of cases were not fibrolamellar carcinomas, but instead were some other mimic. Sometimes there were conventional hepatocellular carcinomas that happened to arise in a younger person. Other times there were serous hepatocellular carcinomas mimicking fibrolamellar carcinoma, et cetera. Now you might be, sort of smiling, saying, well, those Johns Hopkins pathologists, what do you expect? But I just want to sort of reinforce this point that sometimes using just the H&E can be very challenging. And I didn't necessarily cherry pick these fields. These are fairly representative fields of some cases. I'm going to show you two, and just to reinforce the point that the morphology can have overlap. So here's candidate number one. Is this a fibrolamellar carcinoma? Certainly has lots of fibrosis. It's not perfectly lamellar, but as I noted, it's not always lamellar. The tumor cells are big and pink, lots of cytoplasm. The nucleoli are quite prominent, aren't they? You can even see the nucleoli from way up here. So possibly a fibrolamellar carcinoma. How about this one? One of these is a fibrolamellar carcinoma and one is not. And so how about this one? Here again, lots of fibrosis, big pink tumor cells, prominent nucleoli. And you can see that, at least to my eyes, these fields are very similar. But number one is actually a serous hepatocellular carcinoma, and number two is a fibrolamellar carcinoma. Let me just show one other example. I mentioned how some cases of fibrolamellar carcinoma can have more of a solid growth pattern. So here's a liver cancer in a young person, candidate number one. What do you think? Big pink tumor cells? The nucleoli aren't as prominent in this case, but that's okay. Sometimes the nucleoli can be relatively less prominent just depending on the staining preparation. But I think if you look carefully, you can certainly see the nucleoli, and they are quite prominent when you focus on them. How about this one? Here the nucleoli jump out a little bit more, don't they? Big pink tumor cells, young person, definitely cancer. So, which one of these is fibrolamellar carcinoma? Well, the answer is number one. Number one is fibrolamellar carcinoma. So again, in 2005, I decided that I had to find a better way to actually make the diagnosis of fibrolamellar carcinoma before I could do any meaningful studies. And I decided that I wanted to look for a way to confirm the diagnosis by immunohistochemistry, because that's what liver pathologists are particularly good at, is making diagnoses and incorporating additional testing, such as immunostains, to make a firm diagnosis. So in 2007 was sort of the height of the Affymetrix epidemic. We just went through the COVID epidemic, but in 2007 was the Affymetrix epidemic. Everywhere you looked, there was a new study coming out about Affymetrix and gene expression in different tumors. And it was a very exciting time. It was one of the first high throughput molecular techniques that was accessible to everybody, including pathologists. And so it was a very exciting era. And I did my share of these sorts of studies. And I did one on fibrolamellar carcinoma. And certainly, there's some pathways that are upregulated. But I wasn't primarily interested in that. What I was interested in was the potential markers for diagnoses. And one of them that popped out was called anterior gradient 2. Anterior gradient 2 is a protein that's expressed in the developing embryo and helps establish the anterior posterior gradient, and thus it's name, anterior gradient 2. In adults, it's most expressed in neuroendocrine cells, goblet cells of the GI tract, and medium-sized bile ducts of the liver. And so we did a study, and this was my fellow Vivek, who did a great job pulling together some cases and showing that the anterior gradient 2 was strongly expressed in fibrolamellar carcinoma down here on your lower left. Tumor cells are strongly positive. Conventional hepatocellular carcinomas are negative. And you have the added bonus of having some background internal staining. So there's a little bit of zone 3 hepatocellular blush in most cases. And again, the medium-sized bile ducts are positive. And so it was very exciting. I thought we had solved it. It's a great diagnostic marker for fibrolamellar carcinoma. But it soon became clear that nobody was going to set this up. And they weren't going to set it up because even in a busy hospital, you might have 1 or 2 cases of fibrolamellar carcinoma every 1 or 2 years. And so it just wasn't going to work in terms of cost-benefit ratio. So, I had thought about it for a while and was sort of back to the drawing board. But I did know that fibrolamellar carcinomas are routinely CK7 positive, and that had been shown for cases in several studies for a number of years. So I knew that to be true. And I also knew by EM and other studies that fibrolamellar carcinomas have lots of lysosomes. And that's partly why they have such a bright pink cytoplasm. Partly that's because they're enriched in mitochondria, but also because they have lots of lysosomes. So I thought, well, why not use these 2 features together, the prominent lysosomes plus the CK7 staining? Now, CK7 is also positive in about 1/3 of conventional hepatocellular carcinomas. So I knew I couldn't just use that stain, but I thought maybe if I combine them, that'll work. And this study was led by Hilary Ross. Again, it did a great job pulling together cases and showing that fibrolamellar carcinomas are uniformly positive for both the CD68 and CK7. Now, CD68, we used the KP1 clone, and we used that because most labs, at least at that time, that was the clone that was used, and it cross-reacts very nicely with lysosomes. So here's an example of CK7 positivity in a fibrolamellar carcinoma. They're not always going to be this strong and brightly positive, but they will be in many cases, and all cases have at least patchy positivity. Here's CD68. It shows this very distinctive granular cytoplasmic staining. Again, there'll be some variation. Not all cases will be this, sort of uber bright. And many cases will have more of this pattern, where again, you have granular staining of these lysosomes, but all cases will have at least this pattern of positivity. Now, I want to just take a pause here and note that CD68 is not specific for fibrolamellar carcinoma in isolation. So, for example, if you look at the steatohepatic variant of hepatocellular carcinoma, it also has lots of lysosomes. And if you do a CD68, it is routinely positive too. And so here you can see a steatohepatic variant of hepatocellular carcinoma being nicely CD68 positive. But if you combine those stains with the morphology, then you had some helpful techniques to make the diagnosis. So step number 1, again, is the tumor had to look like fibrolamellar carcinoma on the H&E. Then step number 2 was that you can confirm the diagnosis, confirm the H&E impression with additional tests, CK7 and CD68. So we had moved then from the H&E Arab diagnosis, and we now had some additional help, that immunohistochemistry that can help confirm the diagnosis. That era didn't last long because Sandy Simon, a wonderful person, great researcher at Rockefeller, identified a characteristic fusion in fibrolamellar carcinomas. And this is a fusion gene between PRKACA, which is the sort of the money, and the part of the fusion gene that's going to do the work in DNA JB1. And both of these genes are on chromosome 19, and they're right next to each other. So here's a protein PRKACA, and here's DNA JB1, and they're separated by a small distance in terms of genomic distances, 400 kb. And there's a deletion that leads to loss of exons 2 and 3 of DNA JB1 and exon 1 of PRKACA, and exon 1 here becomes fused with PRKACA, leading to this fusion gene. And this fusion gene is what drives fibrolamellar carcinoma. And I'm showing you a picture of protein kinase A, and that's because PRKACA, the gene that has the fusion gene that's part of fibrolamellar carcinoma, is part of a complex that makes up this larger molecule called protein kinase A. Protein kinase A, you probably studied without remembering it way back in biochemistry, because it's one of those sort of like classic proteins that we all study, because it's sort of a paradigm of a protein that's regulated by cyclic AMP levels in the cell cytoplasm. And it was also really one of the best known proteins in terms of studying phosphorylation and how phosphorylation activates and deactivates the kinase. In fact, in 1968, the Nobel Prize was given for the work on how phosphorylation levels regulate protein kinase A. So in any case, this is activated, turned on, and can't be turned off. These regulatory units can't turn off protein kinase A when there is this fusion gene. So we then developed a test to detect this fusion gene. And what we did is we used a break-apart probe strategy, and we put the red probe right where that little bit of DNA that's going to be deleted. So it's going to bind to the chromosome, to the allele when it's there, but it's not going to be able to bind to the allele when there is a deletion. And so here's a normal pattern, red and the green probe. And because they're so close to each other, you get a little bit of a yellow hint to it. You can see them here in normal hepatocytes. But with a deletion, what you're going to get is the loss again of the red probe. And now you can have one normal chromosome and one abnormal chromosome. That will just give you the green signal. And this turned out to work really nicely. And you can identify cases of fibrolamellar carcinoma using this technique, looking for the loss again of that red probe. And it worked beautifully in fibrolamellar carcinomas. We were able to show that those areas of solid growth are typical, and have and still have the fusion gene. There was some literature before we published our paper suggesting that these were combined or mixed conventional hepatocellular carcinomas and fibrolamellar carcinomas when you had that solid area plus some more traditional growth patterns. But we were able to show that that's not the case, that it's all just heterogeneity in terms of the fibrosis component of fibrolamellar carcinoma. And we were able to show that again using this FISH probe, showing the fusion gene present in both components. There certainly are other great ways to detect the fusion gene. Using the FISH probe, we detect the deletion directly. We don't detect the fusion directly, the fusion gene protein itself, but you can have other techniques. You can look for the RNA, the fusion, and there are other techniques that can actually look for the fusion protein. So the technique that we use is not the only one, but it works really well in paraffin embedded, formalin-fixed paraffin embedded tissue. So that's the technique that we rely on. And this study was, the fellow was Oyedele Graham. He did a great job. And we found that the fusion was found in all of 30 fibrolamellar carcinoma cases that we studied. And it was a multi-center study. And, I was in contact with Sandy Simon at this time, and it was similar to his experience where he told me anecdotally that he had tested over 100 cases using PCR for the fusion and found it in all. So we were very confident that this could help confirm a diagnosis of fibrolamellar carcinoma. So the next step was to confirm this in a larger study. And to do this, I approached the Linux Society. This is a liver pathology society that meets annually. In 2016, we met in Sao Paulo. And at that meeting, I talked to people and said, why don't you send me cases and we'll do this test to make sure it works for diagnostic purposes. So cases from all around the world were collected. And for controls, we used conventional hepatocellular carcinomas that were present on a TMA. So to do the step, there's a center review, and I looked at the cases and I divided them just based on morphology into cases that I thought were pretty good for fibrolamellar carcinoma, cases that were possibly fibrolamellar carcinoma, but I wasn't sure and would need to do stains, and cases that I thought were unlikely to be fibrolamellar carcinoma. So the step one was morphology. Step two, we applied the traditional CK7 and CD68 staining. And step three, we did the PRK-ACA FISH. There are 124 cases. And so when I looked at them, 104 cases I thought were perfect for fibrolamellar carcinoma, very typical morphology. 12 I wasn't sure on, possibly, but 8 I was pretty sure were not fibrolamellar carcinoma. In terms of the immunostaining, for the typical fibrolamellar carcinomas, the immunostaining worked really well. 92 cases had confirmation. 12 failed, all because of the CD68, and I'm not completely sure why. We did the staining centrally, so it was our antibody, our technique, and it may be that fixation in different parts of the world led to failure of CD68. I'm not quite sure on that point. FISH was positive in 102 cases, and if we expand on that, the FISH failed to hybridize in one case, and in one case it was negative. And so one of the cases that I thought was fibrolamellar carcinoma based on morphology was truly FISH negative. In terms of the cases that I thought were possibly fibrolamellar carcinoma, but I wasn't sure, the immunostaining supported the diagnosis in 7 cases, the FISH in 9 cases. In all of the cases that, that the immunostaining confirmed the diagnosis, the FISH was also positive. In the 2 cases that were discrepant, again, the CD68 for some reason didn't work. In the cases that were unlikely to be fibrolamellar carcinoma, the immunostaining was positive in 1 case, but again, it was the steatoepitotic variant of HCC, so I was sure it wasn't fibrolamellar carcinoma, and the stains alone wouldn't have led to confusion, I don't think. And FISH was negative in all the cases. Now, I think if you look at it another way, you can see that 11 or 8% of these cases were not fibrolamellar carcinoma. What's I think striking about that is that remember that these cases were submitted all by liver pathologists and all by pretty well-known liver pathologists. I think this just reinforces the observation that the morphology is very helpful and a critical first step, but is not always completely specific. And so the use of additional diagnostic methods are really important. We had 88 conventional HCCs where the morphology was not good for fibrolamellar carcinoma, and they were all negative by FISH. So then that leads us to the molecular era of diagnosis. And so we went from H&E to H&E plus immunostaining to now H&E plus molecular preferred. But if that's not available, then again, immunostains can be helpful. So here it is written out. Step 1, they should look like fibrolamellar carcinoma. That's important. Step number 2, you have to confirm that H&E impression. And I think the preferred methodology now is looking for the actual fusion. But if that's not available, then I think immunostains are also an appropriate backup. So you might be wondering, why can't I just diagnose fibrolamellar carcinoma on the H&E? And you might be an excellent pathologist, and I'm sure that all of us are. But using additional methods to confirm an H&E diagnosis doesn't impugn anybody's diagnostic skills. As I've emphasized many times, hepatocellular carcinomas can closely mimic fibrolamellar carcinomas on H&E, and a significant proportion of cases are misdiagnosed, probably between 10 and 20% of cases, at least in my clinical experience. And if you look in the literature carefully and sort of parse out people's data, it's probably similar there too. So about 10 to 20% of cases published in the literature as fibrolamellar carcinomas, from which molecular data has been published, probably are not fibromelars. And so I think these techniques will help clinically and at the research level. So again, the basic approach is morphology plus confirmation, and that's the best approach for fibrolamellar carcinoma. And in fact, it's really the best approach, the most robust approach for many tumors throughout the body. Here's an illustration. I mean, so my colleague who has an office right next to me, Saba Yassir, brought this case to me a couple years ago, and she said, Mike, is this fibrolamellar carcinoma? And I thought, well, I don't know. I mean, it's like they got big pink tumor cells from prominent nucleoli, but I've never seen a case with prominent, lymphocytic stroma like this. So I wasn't sure. But I had techniques available. So I did the FISH, and the FISH was positive, allowing me to make a confident diagnosis of fibrolamellar carcinoma. So let me return to that large international study that we did. And one of the cases I decided to follow up on because it was an interesting case where the morphology looked perfect for fibrolamellar carcinoma, but the FISH testing was negative. And it was a case from Switzerland. So again, it had correct morphology. The immunostaining had confirmed, but the FISH was negative. And when I asked the pathologist who submitted the case to get more information, it turns out that this tumor had arose in a patient with the Karni complex. I'm not going to go over the Karni complex in any detail, but here's the diagram I took off the internet for you. They have the spotty skin pigmentation, the myxomas, the Sertoli cell tumors of the testes, et cetera, et cetera. And if you look back at that protein kinase A complex, remember that the fibrolamellar carcinomas are driven by a fusion gene that turns on PRKACA, it can't be turned off. Well, the Karni complex results from biallelic inactivation, one inherited, then a second hit of the regulatory unit called PRKARA1. It should be PRKAR1A, sorry, that's a little typo there. So the question then was, can fibrolamellar carcinomas occasionally be part of the Karni complex? And when I read the literature very carefully, I found an old paper in 1987 that did report a single patient that had fibrolamellar carcinoma. And, when I read the literature, again, I found a case, somebody was describing a funny adenoma of the liver called a myxoid adenoma. So this is one of the first reports of this myxoid adenoma. But they also noted in the clinical information that the person also had fibrolamellar carcinoma. And so I didn't have any cases myself, but I contacted people from around the world, and we got together 3 cases of patients with fibrolamellar carcinoma who also had the Karni complex. And the morphology in each case was perfect for fibrolamellar carcinoma. They were CK7 positive, they were CD68 positive, but the FISH in all 3 of these cases was wild type, so no fusion. And when we looked at the protein expression of PRKAR1A in fibrolamellar carcinomas in the Karni complex, there was loss of the PRKAR1A protein expression, whereas it was retained in sporadic fibrolamellar carcinomas. And then, we did sequencing, and I won't go over this in any detail, but just to point out that the sequencing confirmed that these patients had mutations in the regulatory unit of this PRKAR1A regulatory unit, the same, again, gene that causes the Karni complex. So that was expected and seemed to be driving these fibrolamellar carcinomas. We had one late addition to the study, and this case number 4. And this older gentleman also had a typical fibrolamellar carcinoma plus mutations in PRKAR1A, but did not have a Karni complex. So it's possible that in rare cases, perhaps in older individuals, you can have fibrolamellar carcinomas that develop without the fusion, but perhaps through biallelic mutations in PRKAR1A. So fibrolamellar carcinoma, then, I think we can agree is an exemplar of a protein kinase A-driven liver tumor, but it's not the only one. And so the FISH results or molecular testing of your choice still needs to have morphology that's compatible with fibrolamellar carcinoma. So I'm going to show you 3 quick examples of where protein kinase A translocations or mutations or fusions may be relevant to other tumors. And one is there have been reports of protein kinase A translocations in cholangiocarcinomas. Now, I don't have any cases of those myself, but there have been some reports, and here's an example. And they didn't provide an image of their cholangiocarcinoma, so I just put in a stock photo. But nonetheless, there has been some literature, again, showing the possibility of protein kinase A translocations in cholangiocarcinomas. Example number 2. So example 1 is morphology is important. If you look at this, that's not going to confuse you that this could be a fibrolamellar carcinoma because the morphology is not right. And so the overall technique of morphology plus confirmation still works well. Here's an example 2 where clinical findings are important. And so this was a consult case I got from Europe, and it was a young woman who had mesenteric tumor deposits, and they had been biopsied. And the histology was perfect for fibrolamellar carcinoma. It stained completely perfectly, and I did the FISH testing. The FISH was positive for the deletion that leads to the fusion gene, and so I signed it out as fibrolamellar carcinoma. Here's the fibrolamellar carcinoma, good morphology. The staining is perfect. The FISH test positive, but I found out later, you get sometimes get some follow-up with your consults. Only when you're wrong, that's the only time you get follow-up. But in any case, imaging showed nothing in the liver. Nothing in the liver. Instead, instead there's an ovarian tumor. And so the group that had submitted this case wrote this up as a case report. And when the case report came out, I got an email from John Craig. And remember, John Craig is the pathologist who led the study on the morphology of fibrolamellar carcinoma. And he stayed very active in the field since then. And so he says, hello from Carmel. I just saw this paper. And then, he goes on to say, many years ago, Robert Scully sent me a consult of a bizarre ovarian teratoma with fibrolamellar carcinoma in it. And so just to emphasize again that the clinical findings are still important because there seems to be rare cases where you can have fibrolamellar carcinoma tumors rising in ovarian, out of ovarian tumors, presumably teratomas. An example 3, again, reinforcing that morphology is important. Atur Singhi from UPMC has done a wonderful job showing that rare tumors of the bile ducts, and this is intraductal oncocytic papillary neoplasms of the bile duct, can have fusions in some cases that are identical to fibrolamellar carcinoma. Now, diagnostically, if you use those steps, morphology plus confirmation, you won't have any trouble. But if you try to make the diagnosis solely on one or the other, that's where the diagnostic problems can arise. So there's 3 examples where morphology plus molecular is important. I should say morphology plus molecular plus clinical are all important to make the diagnosis. But what about when the morphology is suggestive of fibrolamellar carcinoma, but molecular testing is negative? And so you can consider fibrolamellar carcinomas arising in the Carni complex if the CD68 and CK7 are positive. But there's been another nice paper showing that some of these cases of fibrolamellar carcinoma-like pathology that arise in older patients. So this is a hepatocellular carcinoma in an older patient. And I took selected fields, and the whole tumor didn't look like this, but in some areas it really did look like a possible fibrolamellar carcinoma, some lamellar fibrosis, some pale bodies. In other areas it didn't. It looked more like conventional HCC, but certainly in patchy areas it did. And many of these turn out to have MAP1 mutation. And so that's another possibility to consider when you have a tumor in an older age individual that has some features of fibrolamellar carcinoma. I'm not going to say a lot about the fusion gene itself, but remember, again, back to our protein kinase A, this whole complex is activated because of this fusion that involves PRKACA. And just to say a few words about it, that the fusion kinase is sufficient to cause fibrolamellar carcinoma in animal models, and that is thought to work by overexpression of the protein kinase A and not necessarily by sort of abnormal phosphorylation target. So that, although that's still being studied. Many groups have targeted the fusion kinase for therapy, but it's not been easy. And you can imagine why. This is the ubiquitously expressed protein, and it's a very important protein. And when you inhibit it in the tumor, it's hard to not inhibit it in many other cell types. Immunohistochemistry does not work for diagnostics, again, because it's more of an overexpression issue. And perhaps if we had a specific antibody to the fusion, that would be helpful. But in terms of just looking at total expression of protein kinase A protein, that has not worked. Again, I'm not going to say much more about the actual molecular biology other than to say that it appears to localize properly as the normal protein kinase A should, and seems to function in the same fashion. It just seems to be turned on and it can't be inhibited by the inhibitory unit. Just a few quick words on genetic changes in fibromellar carcinoma besides the DNA JB1 PRKC fusion. Now, there are no mutations in genes associated with conventional hepatocellular carcinoma, such as P53, beta-catenin, ARID2, TERT, etc. And fibrolamellar carcinoma actually does have a small percentage of cases of beta-catenin mutation, but it's a very small percentage, and it probably is a secondary event, so not a primary driver like it is in hepatocellular carcinoma. No microsatellite instability. Different tumors can have hypermethylation of tumor suppressor gene promoters, and we looked at that at Hopkins. And here's fibrolamellar carcinomas, and the frequency of tumor promoter hypermethylation was similar between fibrolamellar carcinoma and H2C arising in patients with no virus and no cirrhosis. And so there's no evidence for hypermethylation as a driver of fibrolamellar carcinoma. Mitochondria changes are certainly relevant in part, and we know that because they have this big bright pink cytoplasm filled with mitochondria. But there's no recurrent mitochondrial deletion that's relevant to fibrolamellar carcinoma. You can have occasional deletions, but nothing that's recurrent. There does appear to be possibly mitochondrial DNA depletion. And so it appears that one of the reasons why the mitochondria are so proliferative is because their DNA content is low and the proliferation is in response to the low mitochondrial DNA content. That has yet to be fully worked out. There have been a fair number of studies doing full exome sequencing. I'll just show you some data that we did in collaboration with Vogelstein's laboratory at Hopkins, where we studied 9 fibrolamellar carcinomas and then some hepatocellular carcinomas arising in non-cirrhotic livers. And so it'd be a reasonable comparison. And just to point out that, everything is fairly similar. The number of mutations is broadly speaking similar. The mean number of mutations per tumor, for example, is 43 in fibrolamellar carcinoma and 42.9 in hepatocellular carcinomas arising in non-cirrhotic livers. And so surprisingly similar. It's really the distinction is the fibrolamellar carcinomas have that fusion gene that seems to be driving the tumor. And just a few words on ongoing pathology-related questions for fibrolamellar carcinoma. One is tumor staging, and this is because the current TMN staging has little predictive power for fibrolamellar carcinoma. It certainly has important predictive power, especially after curative resection for conventional hepatocellular carcinoma. But that same predictive power is not evident for fibrolamellar carcinoma. And it hasn't been fully worked out why, but the general thinking is that a lot of what drives the predictive power of the TMN staging for conventional hepatocellular carcinoma is the ability to pick up risk factors for angiolymphatic invasion. But in fibrolamellar carcinoma, it seems to be the case that the patients who are going to have metastases, probably the tumors develop that ability early on. And so you don't have that strong correlation between angiolymphatic invasion and metastasis with tumor size, for example. And so, we're working on this slowly, but hopefully we can come up with some better way of predicting prognosis after surgery with curative intent for fibrolamellar carcinoma patients. And the TMN staging system that we currently have, you should still use it, but it does not have good predictive power. In terms of tumor grading, like 90% of them of fibrolamellar carcinomas are sort of moderately differentiated. But you do have cases that have nuclear changes that are more in the line of a poorly differentiated hepatocellular carcinoma. And this finding is not completely clear what this means in terms of prognosis. And so that's another ongoing pathology challenge is, again, most of these are moderately differentiated, but what to do in these cases that have more poorly differentiated nuclear changes is unclear. In terms of the future, fibrolamellar carcinoma is certainly moving strongly towards specific clinical trials, and these have been supported by the development of cell lines, by PDX and other mouse models that allow researchers to look for novel drugs that can be used to treat fibrolamellar carcinoma. A lot of work going again into understanding this fusion kinase, how it works. Are there ways to possibly more specifically inhibit this as a therapeutic agent? A lot of this is driven by Sandy Simon, who's got a major lab again at Rockefeller. And this is public knowledge, so it's certainly reasonable to share that his daughter had fibrolamellar carcinoma some years ago. And he's a basic scientist focused on, on basic biology of proteins. And when his daughter developed fibrolamellar carcinoma, he's gradually shifted over his entire lab to focusing on this tumor. And he's made amazing progress. And again, he was the first one to identify this characteristic fusion and has went on to make other really important discoveries in fibrolamellar carcinoma. And that through this work, this will drive to specific clinical trials, I think we all hope, and to therapy that will be highly effective in fibrolamellar carcinoma. So in summary, molecular, or if that's not available, immunostained confirmation of the FLC diagnosis, I think is important. I think we all look at cases that are completely classic and we say, okay, I got this one, I don't need to do confirmatory testing. But when you have that feeling, just remember that 10% of the cases submitted through the Linux Society, and they're all expert liver pathologists, 10% were not confirmed by molecular testing. So I think morphology plus some confirmation is really important. FISH or other molecular testing is highly specific when used with the morphology. And so certainly if you look just at the morphology alone or just the molecular alone, you can come to diagnostic challenges or you can get the diagnosis wrong. The strength comes when you combine those two together. Rare fibrolamellar carcinomas do occur in the Karni complex, and they, a different mechanism, but the same protein kinase A driving the tumor. And these will be negative. And so if you have a case that looks like fibrolamellar carcinoma, but the molecular testing is negative, then consider the Karni complex. And again, if you have a case that looks like fibrolamellar carcinoma, but there's no Karni complex and the fusion gene is missing, then you should also consider the possibility of a BAP1 mutated HCC. Again, these occur in older ages, individuals, and can certainly mimic fibrolamellar carcinoma, at least in selected fields. Especially on a biopsy, it can look a lot like fibrolamellar carcinoma. But here, the age will help, and again, looking for the fusion gene will help. I don't have enough of these cases to look at CD68 and CK7, so I don't know how those stains would perform. And at this point, that information is not available. So thank you very much. I'm happy to take any questions, and I appreciate your attention.
Thank you very much for that, Mike. And I'm sure I must have called something fibrolamellar that may not have been in the past too. So now I'm afraid to go back and look. Anyway, questions, comments? I have one question though. So when you show that example with a myxoid change that was positive for Alcian blue, I started, wondering, when you see something that looks like could be fibrolamellar with those myxoid changes, how confident does that push you away from conventional HCC? Is this something you've seen before? And no?
Yeah, that's a great question. The myxoid change is not common in fibrolamellar carcinoma, but certainly can be seen. And likewise, in conventional hepatocellular carcinoma is not common, but it can occasionally be seen. And so I wouldn't use the myxoid change as a feature that pushed me one way or the other.
Yeah, so that's good. Any other question or comments? Okay. So thank you very much again, Mike, for a great talk.